All right, I think we're ready to roll.
On
All right.
until 8, can I call you then? Sorry, my daughter.
All right. Should I let everyone in? Okay.
Yep, I
So
think we're
just
ready to roll.
admit everyone. All right.
All right. Good evening, everybody, and welcome to the 2024 Cannabis as an Alternative webinar series. I'm very excited to be here tonight with my dear friend and colleague, Dr. Peter Grinspoon, for what is the second of a three-part webinar series where we are digging into really understanding cannabis as a harm reduction alternative. And tonight we will be digging into what are some clinical recommendations that are based on some of the results from a recent study and Dr. Peter Grinspoon's latest book, Seeing Through the Smoke. So thank you everybody for joining. So just by way of background, my name is Dr. Marion McNabb, and I am the president of the Cannabis Center of Excellence. The Cannabis Center of Excellence is a 501c3 nonprofit organization that's based out of Massachusetts that works to bring together academics, policymakers, citizens, patients, community members, and healthcare providers to conduct studies, develop best practices, and document best practices related to medical and adult use cannabis. So I'm excited tonight to be here with my friend, Dr. Peter Grinspoon. I've already introduced myself, so I'll hand it over to you, Peter, to say some words about yourself and your background.
Absolutely. So I am a primary care doctor at Mass General in Chelsea, and I've been involved in the medical cannabis industry for about a quarter of a century. I mean, I've actually been involved sort of my whole life because, number one, my dad was a pretty legendary cannabis scholar named Dr. Lester Grinspoon, and he wrote a book in 1971 called Marijuana Reconsidered, calling for legalization, like right when Nixon was starting his war on drugs. And at that point, about 12% of Americans supported legalization. Now about 70% do. So he really got the ball rolling. And then number two, when I was growing up, my brother Danny fought an unsuccessful battle with childhood leukemia. But the one bright spot was that my parents procured for him some medical cannabis illegally in the early 1970s to use. And it really, really helped him. Like, it was amazing to watch it help him with nausea and anxiety and keeping food down. And he was able to eat. And most importantly to me, he was able to hang out with his little brothers. So I saw from a very early age that medical cannabis had some potential to help people. And then, when I went through medical school, I was always sort of in favor of at least trying it or being open-minded about it and researching it. So I've been treating people with medical cannabis for about 25 years now. And, it doesn't work for everybody, but it works for a lot of people. And it's been interesting and very helpful for my patients. So I'm really happy to be here tonight talking about this great topic.
Yeah, thank you, Peter. Really excited that you are here together with us. So just to ground everybody, we have Peter and I have worked on a three-part webinar series where we've really trying to dig into understanding the role that medical cannabis can play in the opioid epidemic, break down study findings, and really look to see where we can apply some clinical recommendations and policy recommendations for an ongoing opioid epidemic. So our three-part series started earlier this month. On April 9th, we had a webinar where we presented the results of a Cannabis Center of Excellence research study that was focused on cannabis as a harm reduction alternative. We have uploaded that video and several articles up, so you can refer to that after this if you did not attend our first webinar. And here we are tonight, where we're going to be drilling down now more into what are the clinical implications for patients and healthcare providers, which are really for folks that are interested in understanding how cannabis can be integrated as an alternative. And then our third webinar next month will be reviewing a policy memo that our team has put together for different stakeholders in Massachusetts, providing some recommendations based on the research study results, and then also the clinical recommendations that we'll talk about today. So I do want to say a big thank you to those who attended our webinar, our first webinar, and a big thank you to Cannabis Science and Technology and Talking Joints Memo for writing up sort of the webinar findings and results and publishing those. So we will be putting some chats in the link, some links in the chat to where you can go and read up more on those articles or see the video from our first webinar. So I will just give some caveats here that this webinar is being recorded and is currently being live streamed to YouTube. And we will be posting this on the Center of Excellence website with our partners. And the intention is to continue to raise awareness around these important topics and to make this information accessible and free to the public. So within this webinar, feel free throughout the webinar to drop any comments or chats or questions in the chat. And we will definitely be answering and covering those comments. If you have links to other resources or other information that you think folks on the webinar could benefit from, please do also put those in the chat and we will cover them. So for today's outline, I will just very briefly cover a little bit about, give us some grounding about where the opioid epidemic is and the crisis is in Massachusetts. And some key results, not as much as was presented last time, but some key results from our last study to kind of ground our conversation tonight. And then the majority of the time, we will shift over to Peter, where he will read and discuss a chapter in his recent book, Seeing Through the Smoke, that's focused on cannabis and the opioid epidemic, and what are some clinical recommendations from prevention, treatment, and sustaining perspective. And then we'll move into audience Q&A. So I'd like to also really give a huge shout out to our webinar series sponsors. It's for this reason we are able to offer this three-part webinar series freely to the public. So thank you so much for Green Lion Partners, Caroline's Cannabis, and Holistic Health Group for supporting this webinar series and ensuring that we can get this important information out to the public and in a format that is accessible not only to the general public, but also to patients, providers, and policymakers. And also thank you to our media sponsor, Talking Joints Memo. So just to quickly jump in and kind of recount a little bit about where we are in the growing opioid epidemic in Massachusetts. This is a little bit of an update from the webinar, from the data that was reported in our first webinar. As of December 2023, the Department of Public Health has reported over 2,000 overdose deaths just within the last year, in the last 12 months of 2023. And that is a 3% average increase rate in overdoses since the previous years. But specifically within 2023, we see that 93% of the opioid overdoses had some trace of fentanyl detected, which is a highly potent opioid that is really alarming and causing a lot of opioid overdose deaths. Actually, in fact, since 2013 to 2021, one in every 11 people that had a non-fatal overdose in Massachusetts ending up having an overdose, a fatal overdose. And so it's not this is an ongoing battle for folks that are dealing with addiction, of continuing to have overdoses and risk of non-fatality, but also, the increasing risk over time of having ending up with a fatal overdose. The Department of Public Health also reported, you can see here, among those that did have a fatal overdose, several other substances were present, including alcohol, benzodiazepines, amphetamines, xylazine, etc., at the same time. And alarmingly, nearly half of the opioid overdose deaths in Massachusetts are among the ages of people aged 25 to 44, some of the most productive years of our life, and half of the overdose deaths are within that age range. As we mentioned on the first webinar, and we'll talk a little bit more on our third webinar, the Healy administration has announced millions of dollars in funding to address the opioid epidemic, and specifically, funding treatment, harm reduction efforts within the Commonwealth. So back in 2023, the Cannabis Center of Excellence partnered together with Dr. Peter Grinspoon and Alyssa who is as well on this call, and DJ, who are members of the Cannabis Center of Excellence, as well as Eva Rachel Tyne, a leading expert in substance use and recovery and harm reduction in Massachusetts. We were all the leading co-investigators of a cannabis as an alternative research study. This was a cross-sectional survey that was launched in late 2023. We had 586 respondents to the survey. And alarmingly or interestingly, we had a wide variety of those who may be at risk for a variety of types of health conditions and symptoms, who face, including those who are housing insecure. We had 41% of our sample reporting being homeless in the past, or 28% being homeless. We had about a third of our respondents being military veterans, and a third of our respondents reporting as disabled. And about over half of our sample reported having faced opioid use disorder, either now or in the past. And while I won't drill into all of the different research findings, which we did in our first webinar, here are some of the key points that I think in our study relate to what we're seeing as the Department of Public Health is sharing out as some of the greatest challenges related to opioid epidemic and overdoses. In our sample, 23% had used medical cannabis to reduce opioids in the past. 58% reported that they were actively or have used medical cannabis to reduce the use of alcohol in the past. 62% tobacco. And 84% of our sample currently using medical cannabis to reduce the use of substances or mitigate the withdrawal from substances. And this includes opioids, but also other prescription medications. 41% reported that they're actively using cannabis as an alternative therapy for treatment for their health conditions and symptoms. And of those of our sample who reported they were non-cannabis users, 53% of those reported they had a desire to learn more about how cannabis could be used as a harm reduction alternative. So I know that was kind of a lot of data and information thrown at you about where we are in Massachusetts with the opioid epidemic and what our study has found. And they overlap. And, you know, what I'm most interested in now is hearing, now we have seen that patients are reporting that they're interested and they're actively using cannabis to either reduce opioids or some other types of medications or alcohol or tobacco. And what I want to focus on tonight here with Peter, what are some recommendations from a clinical perspective and a patient perspective? How do we, how do we work with people that are interested, either as a healthcare provider, if you're interested in learning more about how do we integrate medical cannabis as a harm reduction alternative, or if you're a patient curious about how you could access cannabis, in lieu of opioids and other substances. So that having been said, my dear friend, Dr. Grinspoon, has just a year ago yesterday launched his new book, Seeing Through the Smoke. I believe it was yesterday. I looked up and I pulled out my book, Peter, and I've got the bookmark, which said 4/22/23. So I think we're right on the mark.
A year ago yesterday was that crazy party we had. It actually came out on 4/20. It came out on 4/20/2023.
There we go. All right, so 3 days behind. And this book is really an incredible resource. I have already don't have the cover on my book anymore because, and you can't see, because I have already spilled coffee all over it. I have, pen marks all over it and the bookmark in here for where we're going tonight. But it is an excellent resource for healthcare providers or, general public or patients even to reference what's the latest evidence related to cannabis. So I'll hand it over to you, Peter, to give a better, more eloquent description of your book and see if you might be interested in sharing a little bit more details about your clinical recommendations from your chapter, Cannabis Instead of Opioids.
Absolutely. Thanks, Marion. Now, the reason I wrote this book is that I think many of the books are either written from a really one-sided pro-cannabis perspective or from a one-sided anti-cannabis perspective. And the fact is, I think we have a lot of common ground with cannabis. I think that most reasonable people would agree that it helps people with chemotherapy-induced nausea, vomiting. It helps people with anxiety, with insomnia, with chronic pain. And then I think, most people would recognize that unless there's a important indication, like, my brother Danny dying from cancer, teenagers shouldn't really be using it very much, and that we don't know that it's safe in pregnancy or breastfeeding, and then it could really trigger or worsen or destabilize people with psychosis. So I actually think there is quite a bit of common ground with cannabis that most people believe in. But the problem is the anti-cannabis people are so adamantly against the idea that there are any potential benefits of it. And some of the pro people are really against the idea that there are any harms. They're like, the government's been lying about this for 50 years, which is true. The US government did a terrible job of really just supporting and publicizing research into the harms, and it wasn't very balanced research. But the fact is that if you're against cannabis, you should want to know how it's helping people. I mean, 94% of Americans support legal access to medical marijuana right now. So if you're someone who's just like dogmatically opposed to it, like the American Medical Association still uses these, condescending quotation marks around the words medical marijuana, like it's this fictitious thing, and they're just so completely out of touch again with the 94% of Americans. Who would have thought that cannabis unites? I mean, name anything else that 94% of Americans agree on, and they happen to agree on that people should have legal access to medical marijuana. So the people who are against it need to be more open-minded about the benefits. And the people who are so completely in favor of it, I mean, I'm certainly in favor of being legalized and people not getting criminal penalties for it, but you should want to know the harms of it so you could make an informed decision. Like, I know the harms of alcohol. I still might have, a beer or two at a barbecue, but at least I know what I'm doing. If people don't know the harms as well as the benefits, nobody can make an informed decision. And then you get this really muddled discourse about it. So this book has my book, Seeing Through This book, has four different sections. One is the social history about the war on drugs. And there's one chapter about physicians and cannabis called Do Be No Harm, about how they were flat out on the wrong side of the war on drugs, which is really just pathetic. And then about the fact that we've arrested more than 20 million people for nonviolent cannabis offenses. And then that sort of raises the question of like, what's actually worse for you, like using cannabis or getting involved in the criminal justice system, which can, most blacks and whites use cannabis at the same rates. And blacks were arrested 4 times as often as whites. And, when you get arrested, it affects your housing, your education, your employment opportunities. So it's been a disaster. The criminalization of cannabis has been a total disaster. Then the second part talks about the harms, and it talks about which of the harms are real and which are imagined. There are definitely some harms that were like fever, dreams of the war on drugs, and to get funding for cannabis research, you used to have to show some kind of harm. The US government supports 80 to 90% of drug research worldwide, and they were waging this war on drugs, and they weren't interested in anything that exonerated cannabis or, in fact, showed that it might have some benefits. So to get any funding to research cannabis, you had to show a drop in something. You had to drop IQ points or, wait, are we still there? Shoot. Oh, sorry, my screen just disappeared. You had to drop IQ points or sperm count or motivation, or you had to drop something. So I talk about what are the actual harms. For example, it is addictive, but it's not nearly as addictive as it's purported to be. A lot of the prohibitionists say that, 30% of adult cannabis users get addicted to cannabis, which is not true. It's much, much lower than that. They rope in with their definitions. They're very, very broad and expansive. They rope in a lot of people with like using medical cannabis with good benefit. So I investigate what actually are the harms. And as I alluded to earlier, I really don't think we know that it's safe in pregnancy. And I think it can be dangerous for teens. And I think it can be addictive, and it really can destabilize people with psychosis. Then the third part of my book is going over the benefits. And really showing what research there is. And a lot of the benefits are really, really strongly researched. And I learned a lot, I learned there's much more than I thought to it about cannabis and autism. Like these kids with autism, we bombard them with like, Adderall and Haldol and lorazepam and all these heavy duty pharmaceuticals, and a little bit of CBD, maybe with a little bit of THC mixed in is a lot safer and more effective in a lot of cases. So I really go through a lot of the benefits, some of which I learned a lot about just writing this book, even though I've been involved in it for the last 25 years. When I talk about what isn't a benefit, like we don't know that cannabis cures cancer. It certainly kills cancer cells in the test tube, but there haven't been any human studies showing that it treats cancer. So I say if you have cancer, you get an oncologist to treat your cancer and you use the cannabis for the cancer-related symptoms. You don't use a huge dose of Rick Simpson oil to try to treat your cancer. I think that's like sort of suicidal. So I talk about like what the benefits are and what some of the benefits people think there are that actually there aren't, according to the data. And then my final chapter is about, or final part is about lifestyle enhancement, because people have been using cannabis for thousands of years, and it's not just for medical benefits. It actually makes them, appreciate sex, art, music, beauty better, nature better. Helps them connect with other people. It helps them with their creativity and their focus. So I talk about lifestyle benefits as well. So that's the broad outlines of what my recent book is about. And then, as Marion alluded to, I talk specifically of one chapter about cannabis and the opiate crisis. Marion, is that what we want to talk about now?
Yeah, sure. Yeah.
All right, I'm basically stalling for time so I can guzzle some coffee. Again, I've been doing this for a long time, for 25 years, treating people with medical cannabis. And also, I have sort of a unique vantage point in that I'm 15 years, actually more like 17 years now, in recovery from opiate addiction. I got addicted to prescription painkillers, and then I managed to get off prescription painkillers, which was not easy. And then I managed to, I got hired to help work with physicians who are addicted, and I helped hundreds of physicians who are addicted to opiates. And as a primary care doctor, you deal with tons of addiction. You probably deal with more addiction than the psychiatrists do because you see so many patients and so many people are addicted. So I help a lot of people with opiate addiction. And we treat tons of people, like tens of millions of Americans have chronic pain. And it's very difficult to treat chronic pain because what are your options? The Tylenol doesn't do anything. Nobody wants to be on opiates these days if you could even find a doctor who will prescribe it. And the non-steroidals, your ibuprofen, your Advil, your Motrin, your diclofenac, first of all, they kill 10,000 people a year from heart attacks. And then after that, they cause a lot of bleeding and a lot of bleeding ulcers. And then I see so much kidney disease from people taking ibuprofen after ibuprofen after ibuprofen year after year after year. People think if it's over the counter that it's harmless, but that's absolutely not the case. So I really focused on the ways in which cannabis can and can't help alleviate the prescription or the overdose crisis. The opiates went up last year, the deaths from 107,000 to 108,000. I mean, that doesn't sound like a big increase, but the fact that we have 108,000 people dying from opiate overdoses is just a disaster. I mean, I think there are a lot of things we could do to help this with safe injection facilities. And I personally think if we decriminalized opiates and created a pathway so that people can get opiates, people who have chronic pain or people who are addicted and withdrawing without having to buy illegal opiates on the streets like fentanyl, then you wouldn't have people dying from fentanyl overdoses. But specifically with cannabis, there are 5 potential ways in which cannabis can help with the opiate crisis, 4 of which I'm a big advocate of. And the 5th one is a little bit more complicated. We'll discuss at the end. The first one is if you have a new chronic pain patient, instead of throwing OxyContin at them like we did 20 years ago, you could treat them with medical cannabis. Someone has very, very severe pain, they might need opiates, but most people can get by with medical cannabis. And interestingly, if you compare cannabis to opiates for chronic pain, the health-related quality of life is always much, much higher in the cannabis group. Opiates make you constipated, itchy, they cause falls, they make you sleepy, and cannabis just gives a much higher quality of life for the same level of pain control, which is why a lot of people are very interested in cannabis, just like they are psychedelics and sort of hospice care, end of life care, because instead of having your dying loved one drugged down on opiates, they could be much more with it and connected and conversant on cannabis. So starting new patients on cannabis instead of opiates is one really good way. The fewer people on opiates, the fewer are going to get addicted, and the fewer opiates are lying around in someone's medicine closet for someone else to get addicted to. Number 2, you could offer to taper people. We have a lot of people on large doses of opiates because we've prescribed so many of them in the past. And there's very little evidence that opiates are good treatment for chronic pain. But at the same time, it's hard to get people off the opiates because they go down on the opiates and they feel withdrawal symptoms and they confuse that with pain control and they want to stay on their opiates. But we can use cannabis to transition people off of opiates. We taper them down off the opiates and up on the cannabis. And a lot of people do really, really well. the one caveat I want to say is that it needs to be voluntary. I don't believe in cutting people off their opiates. If you cut people off their opiates, you have higher suicide, you have higher depression, and the people get desperate and they buy it on the streets, and then you get overdoses with like the fentanyl. So voluntarily, I offer to transition people off the opiates and onto cannabis. And I've had a lot of success with that. The third way in which cannabis can help with the opiate crisis is you could lower the dose of opiates if you give it together with cannabis. They sort of co-work on the same receptors. So some studies have shown that you can lower the dose of opiates by like 80%. And given that a lot of the overdoses and a lot of the other mischief you get into with opiates is dose related, that's a huge deal if you can cut the opiate dose by up to 80%. One way of looking at it, some researchers have described it as there's like a 1 + 1 = 3 phenomenon with cannabis. Like you give someone like 2.5 milligrams of oxycodone, it doesn't help with pain under experimental conditions. That's like half a Percocet. You give like 2.5 milligrams of THC under experimental circumstances, that doesn't really help with pain. That's like half a puff. But if you give the 2.5 milligrams of oxycodone and the 2.5 milligrams of THC, then you could get pretty good pain control on a subtoxic level of both these medications. So they work in a synergistic manner. And you could not only lower the side effects of opiates, but you could also lower the side effects of the cannabis, which tend to be much, less harmful than the side effects of opiates. But so the third way is you can reduce the dose of opiates by co-treating with cannabis. The fourth way in which I think cannabis can be really helpful for the opiate crisis is for the opiate withdrawal symptoms. As someone who's been through these dozens of times, fortunately not for like 17 years, but quitting opiates over and over again, you're nauseous, your stomach's hurting, you have diarrhea, you're shaky, you feel feverish, your nose is stuffed up, you're anxious, you're depressed, you can't sit still, you can't sleep. It's just miserable withdrawing for opiates. And there are very few medications that the medical community gives because they're not very effective for pharmaceuticals for opiate withdrawal. And cannabis is phenomenally effective. You still feel like you're miserable, but you don't feel like you're going to die. And I found cannabis to be just spectacularly effective for opiate withdrawal symptoms, both myself and in probably like hundreds of patients I've treated. People sometimes these Suboxone clinics will test you to see if you're on cannabis or other drugs and then kick you out if you test positive. But that's absolutely like unethical and the wrong thing to do because people don't do worse on Suboxone if they're using cannabis. Some studies show they do better. Some studies show there isn't much of a difference, but they certainly don't do worse. And if they're that much more comfortable and the noxiousness of the opiate withdrawal symptoms are what cause a lot of people to relapse. So if we could treat the withdrawal symptoms more effectively, we're going to prevent relapses, overdoses, and deaths. So the fifth way in which cannabis could help the opiate crisis is if you used it directly instead of the opiates, sort of like we use methadone or Suboxone as a medication for opiate use disorder, to transition them directly from the opiates onto cannabis. Now, we've had tremendous success with methadone and with Suboxone or buprenorphine. There's been a 50 to 80% reduction in both overdoses and deaths from overdose. Now, why know of thousands of people who have used cannabis to get off opiates? If I'm the prescribing physician in my clinic, I'm going to go with the Suboxone or the methadone because that's where the data is. And then use the cannabis for the withdrawal symptoms, for the anxiety, for the pain, for the insomnia, for the things that sort of sustain your addiction. Cannabis can help undermine the addiction by treating these things that are often untreated, which contributed to the addiction in the first place. But I just am not quite there yet for giving cannabis directly when someone walks in for opiate use disorder instead of giving methadone or Suboxone. Because again, that's where the data is. I wouldn't be surprised given how many people talk about how cannabis got them off opiates if in 10 years we do have the data and we are using this. And there's some very interesting programs in certain states where, like, I think in Illinois, this came up during our last webinar, you can give your opiate prescription, exchange it for medical cannabis. So they obviously are having success with that. So in a nutshell, I really do think that cannabis is integral to helping address their opiate overdose crisis. Though I do think that it's more helpful if you use it to treat the symptoms of withdrawal or the symptoms of chronic pain or anxiety or insomnia rather than directly using it to replace the opiates. Not quite ready for showtime yet, but overall, I think it has tremendous potential. And every day I see people using cannabis to help with their opiate addictions, and they overall tend to do well and to be very happy with their treatment.
Yeah. And, I think those are just 5 different, very practical ways that you can introduce cannabis at different points in time. And I wonder from your clinical experience, I mean, and it's so important to have this information out there, and, as an alternative because, and I'm curious from your clinical practice, and more recently, it's getting harder and harder for people that are addicted to opiates to maintain their, prescriptions, right? Are there challenges that are going on now that are forcing patients? Or I'm curious from your clinical perspective, more recently, what are some challenges that patients face in maintaining their opiate prescriptions, and what are some, and I know you've already touched upon some of the reasons, very rational reasons for why people would want to, transition to cannabis, but what are some challenges that people face currently when they're getting treatment, and does cannabis, would there play a role there?
Well, first of all, the way the US government's responded to our opiate crisis is by to crack down on doctors and bludgeon them and intimidate them and even prosecute them for prescribing too many opiates. And all that's doing is making it harder for patients to get opiates that they're going to take anyways because they're addicted or they're really reliant on them for chronic pain. And that's why they end up buying them illegally on the street. And that's why overdoses go up. I mean, we've been cracking down on doctors for the last 2 years, and the overdoses from fentanyl have just gone up steadily. That is absolutely the wrong approach. It's the most drug worry, pea-brained approach to like the opiate overdose you could even imagine. Only the DEA would think of that. Like completely unhelpful. Another illustration of this is, doctors shouldn't be drug dealers, and they shouldn't be just giving out Suboxone. You give me $200, I give you Suboxone. These pill mill doctors are not doing the right thing. But or you give me $200 and I'll give you a prescription for oxycodone. But at the same time, every time they arrest or shut down a pill mill doctor, the overdoses in the surrounding area go up because people lose a safe, regulated supply and end up having to buy unregulated opiates on the street, which is contaminated with God know what, with nitazines, with xylocaine, with different types of fentanyl. It's absolutely awful. So if they're going to go after these doctors, they need to find a way to prescribe, to allow people to have a reasonable, regulated, safe access to these medications. So I also think stigma plays a big role, like the pendulum switching. Like doctors were way too loose about prescribing opiates in the 2000s. And that's why so many people got addicted to OxyContin. But now the pendulum swung, and we're really partially under pressure from the DEA, but partially because of a cultural change. We're really like not free enough with opiates. And it's really inhumane to undertreat someone with severe chronic pain. I mean, our first mandate is to do no harm. And tell me that's not harming people by not giving them enough pain control. It's absolutely awful. You hear about people going home from surgeries and they're given like 3 Percocets, and it's just awful. We have to be not lose our humanity in the rush to like solve another problem. And so I really think we're sort of under-prescribing opiates. But medical cannabis, this is where medical cannabis really does play a big role. I mean, as I alluded to before, I've definitely got a lot of people off, not just opiates, but off benzodiazepines, and their health-related quality of life always goes up. But recently I had patients say, I got off the Valium, I got off the Percocet, I'm doing a lot better with the medical marijuana, but, it cost me $150 a month, and my Percocet was $1 a month on Mass Health, and my Valium was $1 a month on Mass Health. So I can't afford $150. I mean, I work in Chelsea, where it's not the richest patients, but people couldn't afford, like, it's much more affordable, $2 a month than $150 a month. So I think it would really help if we got health insurance to pay for the medical cannabis. And the health insurance are making such a killing off the fact that people are using cannabis instead of all these other traditional pharmaceuticals that the health insurance companies have to pay for. Like in 2016, there was an article in the Journal of Health Economics that when Colorado legalized recreational cannabis, the Medicare D costs for all of the conditions where they could use cannabis instead of pharmaceuticals went down, and they were saving hundreds of millions of dollars on Medicare D just because they legalized cannabis. And this wasn't with anybody doing anything or trying to come up with savings. This is just organically helping. And if doctors knew more about cannabis and if they were actually helping people, and if we were providing this and paying for it, the harm would be reduced drastically. So I think there's a lot more we could do, but I think we're generally heading in the right direction as legalization is spreading and as people are sort of reevaluating the benefits versus the risks of cannabis from beginning to end.
Yeah, yeah. Thank you. And there's also, encouragingly, I mean, just to build on your point of health insurance coverage, several states are looking into, I know New York, for example, is looking into coverage for medical cannabis because of the cost savings that it may have, and also improvement on the quality of life. And as you rightly mentioned, I think our healthcare providers definitely need to know more information about the endocannabinoid system. I think on our last webinar, we ended up saying, it's definitely less than 20% of medical schools teach about the endocannabinoid system or any, sort of non-risk-based cannabis education. I'm curious what your, thoughts are and recommendations are. I mean, I know that you educate a lot of healthcare providers. What do you think is the one or two most important pieces of information that a healthcare provider should know? And do you see that there's any differences among different specialties? So I know that we've talked a lot about the addiction world and addiction clinicians. Is there one solid piece of advice that you could give to all of them, or would you need to
No, absolutely.
approach them differently?
First of all, it's just weird that we don't teach the endocannabinoid system in medical schools or don't very often. Now, first of all, even if you're against cannabis and you think it's like satanic lettuce, you need to understand the endocannabinoid system to explain why you think it's bad. And even if you're cannabis agnostic or cannabis neutral, like the endocannabinoid system is a really, really central neurotransmitter system that in many ways controls the other neurotransmitter systems and is in charge of like really basic processes like reproduction, memory, learning, emotional regulation, temperature control, appetite, feeding. So it's just weird that we're not teaching the endocannabinoid system, regardless of cannabis, is like this critical system that we need to be teaching people. And as an added benefit, they'd actually understand cannabis and why it might be harmful and why it might be beneficial. Now, my theory has always been that like what vantage point a particular clinician has into medical cannabis really determines his or her attitude towards it. On the one hand, you have the oncologists, like 90% of them support medical marijuana. And that's because they see their patients benefiting. These miserable patients with cannabis are able to hold food down or not be up all night barfing and can get some sleep or can deal with the cannabis pain without taking a ton of opiates. So most oncologists are in favor. And the other end of the spectrum is like, for example, the adolescent psychiatrists who see the rare but very tragic cases where a young person smokes a lot of cannabis and that either triggers or contributes to or destabilizes their psychosis. And they tend to overgeneralize and think that cannabis does this to everybody. The fact is, the truth is somewhere in between. I think primary care doctors, like 2/3 of them, now believe that cannabis is a helpful and effective medication. It was in the U.S. Pharmacopoeia in the 1950s, excuse me, in the 1850s, in the latter half of the 1800s and the early 1900s, before it's criminalized, cannabis was a well-respected, well-used, and well-tolerated medication in this country. And it wasn't until, for no health reasons whatsoever, just for political reasons, they criminalized it in 1937. And then in the 1940s, they stripped it out of the pharmacopoeia. But cannabis didn't stop being a medication. It just stopped being sort of in favor of because of the drug war. Hopefully now they'll put it back in the pharmacopoeia now that 94% of Americans support legal access to medical marijuana. And now that most doctors at least understand that their patients find it really, really helpful. And now that the research is a little bit more fair and balanced, we're learning a lot more. We're proving a lot more about the harms that we sort of knew about all along because so many patients tell us about it. And why would the patients lie? Why would the patients say my sleep is better? Because then they don't get an Ambien. Or why would they say my pain is better? Then they don't get opiates. There's no reason whatsoever for the patients to somehow lie about how cannabis is helping them. So, but it's very difficult with the physicians because there's not a lot of consensus. The psychiatrist just came out with a paper last year in the American Journal of Public Health saying cannabis makes anxiety, depression, PTSD, and psychosis worse and shouldn't be used to treat any of those. Now, none of the people that wrote this paper have ever treated a single patient with medical cannabis, which sort of begs the question of how they'd have any idea if it works or not. But I agree with them about the psychosis, but it absolutely helps people with anxiety, depression, and with PTSD. So, but I think it's very difficult to come up with like caregiver education if we don't have enough common ground that we all agree upon. So, that's a work in progress.
Yeah, yeah, absolutely. And one that is important to continue to work on. I would encourage anybody who's on this webinar, if you have a question or a comment, please feel free to plop it in the chat. I have another few questions to keep going on, but if anybody has anything they would like to ask, please feel free to jump in. So, Peter, there are, as cannabis is becoming more legal across the United States, more widely accepted, right? And legal for medical use and adult use. I think we're starting to see a number of new consumers, right? Maybe consumers who have maybe they're elderly or baby boomer consumers who have, potentially consumed cannabis in the past, which was potentially a much different type of cannabis than the potency and the amount and the types of products that you can access today. So we're seeing like older populations are being one of the fastest risers of cannabis adoption. And a lot of these older populations also, still are on their polypharmacy, they may be on opioids themselves for chronic pain or a variety of other sort of conditions. Have you seen, sort of anything related to senior populations or anything unique in any other populations that might be interested as new consumers?
Well,
And what would you tell them?
the senior population is growing more rapidly by far than any other demographic. I mean, it went from like 2.4% to like 4.2%, and now it's even higher than that. People are hearing about it from their kids, from their like friends, from their, sort of people that live in their assisted living facilities with them, and they're hearing about it. And, they're finding that it really helps with as you mentioned, the polypharmacy. Like polypharmacy is defined as like being on 5 or more drugs. I have some patients in their 80s that are on like 20 drugs because they have a lot of different problems. And, as you get older, you accumulate diagnoses, specialists, and medications. And to be on that many medications is really not only really expensive, but also really confusing and really dangerous. It's really easy to make a mistake when you're on that many medications. And one thing about cannabis that's interesting is that it can do several things at once. If a person has chronic pain, say they have like something like fibromyalgia, it can help with the pain. It can help with the perception of the pain, meaning that you still know that you're in pain, but it doesn't bother you as much. So you can do other activities. It can help with the anxiety about the pain. It can help with anxiety and depression, anxiety in general and depression. And it can also help with your insomnia. So that's why the health-related quality of life invariably goes up when people start medical cannabis. Well, most people, not everybody. Some people have a bad reaction to it. Some people, it just makes you really sleepy, and other people, it makes anxious. Not everybody can take medical cannabis, but certainly older patients are finding it to be extraordinarily helpful. Again, one of the challenges is how to pay for the cannabis if you're on a fixed income, if you're a veteran or, on Social Security. It's hard to pay for it, but they're finding it to be really liberating from a lot of the pharmaceuticals, the pill after pill after pill that they're taking, and they're finding it to be relatively non-toxic. I mean, you have to be careful with memory, with impairment, with balance, with walking, with falls. But generally speaking, compared to your Ambiens and your opiates and your non-steroidals, which are lethal, and your gabapentins, people are finding cannabis to be very, very helpful for a lot of the suffering, a lot of the symptoms that they're suffering through. So yes, I think it's changing, and with widespread acceptance and with a diminishment of the stigma, these patients that really, really can benefit from it are now feeling, more emboldened to ask their doctor about it. It's a different discussion if a patient says, "Oh, I used cannabis in college. I loved it. I haven't used it for 40 years. I'd like to start it." You know that they're not gonna have a bad reaction to it, and you can start them up more rapidly. But if someone comes in like they're 85, they're like, "I've never used marijuana, but I hear it helps with my arthritis. Can I try it?" You'd want to start like really slowly and go up really carefully just to get them used to it and to make sure they don't overshoot and have a side effect or a bad reaction. So, but generally speaking, absolutely, older Americans, I think, is like this drastic sea change in how they perceive cannabis and in the rates of their use. It's been really fun and interesting to watch.
Yeah, yeah. I agree. They are the fastest growing and curious, and many have tried in the past. And so now, thinking about the new products, these new products are much more potent. So you talked about recommending, start low and go slow. What level of start low is that? Is that a 2.5 milligram? Is that a 5 milligram? Is that dependent on whatever somebody comes, with their particular health conditions and
Well,
symptoms?
first of all, the prohibitionists make a big deal of like cannabis is much stronger now. It's not your grandmother's cannabis or whatever they say. Um, and when I was growing up, it used to an argument against cannabis would be like, oh, you have to smoke a whole joint. That's bad for your lungs. It's so weak. And now the argument is it's so strong, you only have to take one puff. It's bad. It's like the plant can't win. But I do think that that the main harm of it being so strong, first of all, I think several harms. One, we fetishize high THC. And I think that if we bred down a little bit of the THC and bred up some of the more medicinal other cannabinoids like CBD and CBG and CBN, the whole thing would be safer and more medicinal. Second of all, the problem with super high THC is that people can overconsume. They go to a dispensary and the bud tender's like, doesn't realize they have a tolerance. They're like, hey, try 100 milligram beverage. And like, you really want to start someone at like the smallest dose and work their way up, especially if they're not used to it. And then this is just a recipe for people taking way too much. And nobody dies, but you have a miserable experience. It can be very anxiety provoking and it can turn you off from the whole endeavor. So, if a puff is like 5 milligrams, an average person, I'll start on 2.5 milligrams, and just for a couple of days, and you can work your way up. But I say to them, if you're going to make a mistake with the dose, we're going to make a mistake where we don't take as much and we're slightly disappointed rather than we're going to take too much and have a bad reaction. If it's someone who's never used cannabis before and they're older, they 80, they're on a bunch of different medications that it could interact with, I wouldn't be against cutting a gummy bear, mangling a gummy bear into 4 pieces and starting with like 1.25 milligrams. There's no harm in starting with a really low dose. It just takes a little longer to get to the right dose. And like, again, the last thing you want to do is overshoot. And then like with any medication, you want to use the lowest effective dose. And the only way you're going to figure out the lowest effective dose is if you start really low and work your way up slowly. So I do think that like caution is warranted and that you could really avoid most of the bad experiences that people have if you just start really patiently and cautiously.
Yes. Thank you for that. And I think it is really important. When I first started studying cannabis, it's now 7 years ago, goodness. I was hearing a lot of new markets open up, right? A lot of new medical markets, a lot of new adult use markets open up around the United States. And a lot of people getting very, very excited going in, purchasing, maybe they're a new consumer, purchasing cannabis, not finding the right fit for them, and then we've lost them as a potential cannabis patient because they didn't have a great first experience. So, really being thoughtful about how do we educate patients, about starting low and going slow, and about how cannabis interacts with different health conditions. I think will keep people, in the system, so to speak, if cannabis is right for them. We have just a few more minutes, and I have another question for you, Peter. Many people in our research study reported using cannabis to reduce the use of both alcohol and tobacco as well, which are also much more lethal substances. I'm wondering if you've seen any of that in your clinical practice or, in any of the times that you've been working with patients.
Well, absolutely alcohol, less tobacco. First of all, it's crazy. We're talking about rescheduling cannabis to Schedule 3. Right now it's Schedule 1, no medical utility, high abuse liability, both of which are complete nonsense. It's just put there because of the drug war. It doesn't have anything to do with the reality of cannabis. But they're talking about like rescheduling it to Schedule 3, which is like anabolic steroids or like Tylenol with codeine.
Mhm.
Which makes no sense because you get more than half Americans live in a place where you could just go out and buy cannabis. Why don't you go to your doctor, try to get a Schedule 3 substance, and then deal with the insurance company saying, no, you can't have that. But the fact is, tobacco and alcohol are completely descheduled, and tobacco kills about 500,000 people a year. And alcohol last year killed 172,000 people. Cannabis kills about 0 people a year. So it's absolutely nuts that cannabis is scheduled and going to be rescheduled, where alcohol and tobacco are descheduled. Now, I haven't had a lot of people switch tobacco for cannabis. Like, I think that tobacco is like really, really, really addictive. They do experiments, they get rats addicted to tobacco or nicotine and heroin, then they take away both and they give the rat a choice. And half the time the rat will pick the nicotine, not even the heroin. That's how addictive it is. But I've had tons of clinical success getting people to transition from alcohol to cannabis. People find it less fattening, less of a hangover. They're happy that it doesn't cause liver disease, cancer, heart disease, esophageal cancer. I mean, cannabis is just so much safer than alcohol. And, in a perfect world, we'd have a less stressful society and people would like exercise and meditate and be mindful and do yoga and eat tofu and not need anything at the end of the long day. But in reality, people have these really stressful jobs and these stressful lives, and most people need something at the end of the day. And you look at how vastly safer, not just safer, but more helpful cannabis is. It doesn't make people violent. It makes them like connect with other people. So a lot of this is happening organically. I mean, for the longest time, alcohol was the only legal option. And, a lot of people don't like breaking the law. Some of us have always not really cared as much, but a lot of people don't like breaking the law. But now that people have a legal choice between cannabis and alcohol, they're going to be finding the cannabis again is like healthier and more interesting and more helpful. So I think that both clinically, when someone's addicted to alcohol, you can use cannabis to transition them off, but also organically, as our society makes a shift from alcohol to cannabis, that is harm reduction at its best. Again, nobody's claiming that cannabis doesn't have any harms, but it's certainly on every possible metric less harmful than alcohol. So I think that's going to be a huge, huge improvement.
Yeah, absolutely. And from the tobacco perspective, I have been seeing the role of CBD and, CBD, hemp-derived CBD smokes out there, to help with anxiety, to help people transition off of nicotine. But to your point, nicotine is a very, very, very strongly addictive substance. And yeah, so more work to be done on that. So we only have about 2 minutes left. So I wonder, Peter, if you have any sort of last wrap up points or advice that you would give to any patient or any healthcare provider on this topic. And then we will move into sharing more about our next webinar.
Absolutely. Well, I think the most important thing is open, clear, honest communication between caregiver and patient, doctor and patient, nurse and patient. And I think doctors haven't done a very good job, partially because they don't know anything about cannabis and they have a hard time talking about it, and partially because they've been sort of propagandized against it. But if you're a doctor, no matter what you think of cannabis, if you're anti, if you're neutral, agnostic, if you're pro, you need to know enough about it and to have a good enough attitude to meet the patient where they are and to have a sensible discussion. Because if you don't, the patient's just going to go talk to their bud tender and you won't even know that they're using cannabis. So I think doctors could do a lot better job. And I think educating physicians about cannabis is going to go a long way towards helping that. And just with time, as the stigma dies down and as physicians see more and more of their patients benefiting from medical cannabis. For patients, I think it's really important to at least try to talk to your doctor, because there are medication interactions and it's much better if the doctor knows what you're doing. This is true for all drugs, alcohol, opiates, not just cannabis. So I think both doctors and patients need to make a very big effort to have helpful, thorough, open, honest communication about this. I think that this will make the whole enterprise a lot safer and more productive.
Awesome. Thank you. And I agree with that wholeheartedly. Awesome. So I want to thank thank you so much, Peter, and thanks everybody for joining in on this webinar and this interesting and important topics. Next up, want to give a quick plug for the Cannabis Center of Excellence. We've just launched a new website. So in case y'all are interested in learning more, with support of Gibby's Garden and Keefe Studio, we now have all of the research studies and data that we've collected over the last since 2018. Now accessible in a much easier way and format for folks that are interested to learn more and read blogs and the data points from any of these research studies, including the research study that Peter and I have chatted about today. So please do visit. We've just launched a new resource portal. So feel free to check out the Cannabis Center of Excellence and support us if you're interested, and reach out to us if you are interested in conducting any research studies or educational programs. So our next webinar will be the final out of this 3-part series, which will be on May 23rd. And this webinar, we will be focused on the policy recommendations that were put together and shared with Massachusetts stakeholders. I think these policy recommendations, even if you're not from Massachusetts, might be helpful in your own jurisdiction. But based on what we've talked about today and the research findings, we have put together some recommendations that we will cover next time. So without further ado, I want to thank everybody for being a part of this webinar, joining in, and for your interest. And we will make this recording available on our website. And thank you so much, Peter, for sharing all of your wonderful insights and guidance with us.
Well, thank you, Marion. It was really fun and it was a great webinar.
Yeah, thank you. And thank you all. And we hope to see you next month. So.
Right. Bye-bye.